All right, we do have a full agenda today, so I'd like to get started. My name is Bill Keck. I'm chair of the Council on Linkages, and it's my pleasure to welcome the council members, speakers, and other guests to our meeting today. I really want to begin, as we always do, with giving our thanks to the Centers for Disease Control and Prevention's National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce, because they're the ones who provide the funding that supports the council's activities. I think it's good for all of us on the council to remember that. And Mayela, if you would, perhaps some opening tidbits to help us facilitate the meeting?
Yes, absolutely. Audio is available via both computer and phone. We ask that you please keep yourself on mute when you are not speaking. We do encourage you to turn on your video and to put comments or questions in the chat box at any time, and to open your audio line to speak during discussions. This meeting is being recorded. We use the recording for note-taking purposes, but it may also be shared publicly. And as always, please feel free to send me a chat at any point during the meeting if you have any technology or audio problems. I am Mayela Arana, PHF Webinars. With that, I'll turn it back to you.
All right, thank you, Mayela. I want to begin by reminding folks of what our mission is. As you can see on the screen, it's to improve the performance of individuals and organizations within public health. And we do that in three major ways. One is fostering collaboration among public health entities. Another is promoting public health education and training. And the third is developing and advancing innovative strategies to build and strengthen public health infrastructure. To do this work, the Council brings together these 24 national organizations shown on the next slide, plus the staff provided by the Public Health Foundation to focus on workforce development initiatives that will broadly benefit the public health population health workforce. So our agenda for today, as I mentioned, is a full one. It's on the screen, and I think all of you have had the opportunity to see it ahead of time. Let me ask if there are any additions to the agenda. Any additions to the agenda from council members? All right, hearing none, then we'll assume the agenda is appropriate. And we go on now to the minutes. Mayela, do we have a quorum? Do you know?
We do.
We do. Okay. Grace, thank you very much. So you've had the opportunity to see the minutes from our last meeting held on March 1st, 2024. Let me ask, please, for a vote to accept the minutes as presented, excuse me.
Chair, I would so move, and also acknowledge the accuracy and the completeness of those minutes.
Thank you so much, Gary. Do we have a second from council member?
I can second those.
All right, thank you. Now, any additions or corrections to the minutes? Hearing none, then let me call the question. All those in favor of approving the minutes from March 1, please say aye.
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 This is council members or their representatives only, of course. Do we have any abstentions or any negative votes? Thank you all. The minutes are adopted. And with that, I'll turn the meeting over to Ron to introduce the next subject and the speakers associated with it. Ron, so please, floor is yours.
Great. Thank you so much, Bill. Appreciate it. For those of you who've been attending recent Council on Linkages meetings for, I guess now over 2 years, a standing agenda item we have had has been focusing on rebuilding the public health workforce. And in the past, many of our meetings, we've talked about the Public Health Infrastructure Grant program and ways that the Council on Linkages members can help that program be successful, in particular with its workforce development components of that program. For today's meeting, we're going to do something a little bit different. Our discussion will focus on an initiative to improve public health advocacy skills. More than ever, we are seeing advocacy as a critical need in public health. However, recent studies show that public health professionals may still be unprepared to engage in advocacy. So the Public Health Advocacy Consensus Task Force is formed. It's an initiative of the Lerner Center for Public Health Advocacy at Johns Hopkins Bloomberg School of Public Health, and also supported by the de Beaumont Foundation. And this initiative aims to build stronger and more effective advocacy competency training to improve public health policy at the federal, state, and local levels. And through partnering with national and state public health organizations, the task force is working to gain a consensus on the definition of public health advocacy, identify the essential skills needed for public health advocacy, and draft guidance that could help public health schools and programs in providing advocacy training. So today we are joined by 3 speakers who will tell us more about this initiative and who have been invited. They've also invited the Council on Linkages to become a sign-on lead organization of this initiative. Today's speakers are Elaine Auld. Elaine is a Task Force Advisory Committee member and also former Chief Executive Officer for the Society for Public Health Education and a long-term Council on Linkages participant. We are always pleased when Elaine can be with us. We also have Megan Ames, who's the Education Program Manager of the Lerner Center for Public Health Advocacy at Johns Hopkins. And finally, we have Glenn Schneider, Glenn, who is the Director of the Public Health Advocacy Consensus Task Force. So let me turn it over to you now, Elaine.
Well, thank you very much, Ron, and thank you, Dr. Keck, and good afternoon to all of you. I appreciate so much a robust response, especially during this summer period. But I want to just get started by saying, you know, Sophie's been a member since I think the first discipline-specific member of the council, and it has been we have really looked to the council for guidance and direction on improving the training that we do in health education to our students as well as our professionals. So thank you for all of the leadership that you have provided over the years to start. And I want to give a shout out to Dr. Michael Fagan. Oh, I see he's on the call today. I'm so happy because he's been our liaison for many years and keeping the Sophie board updated on what's been happening in the council and prodding us from time to time on when we need to take action. So although I've recently retired, I guess I call it rewired from Society for Public Health Education, I'm here today as the part of the FACT Advisory Committee. And it's partly because advocacy has always been my passion. When I first started with Sophie and the organization moved from California to DC, we saw so much potential to be involved in advancing the public's health through advocacy. So I'm just going to get started for a few minutes to introduce and give you a little context for this initiative and why, you know, I stepped forward and Glenn was so gracious to have me on the advisory committee to see this initiative moving forward. Next slide. I guess for me, and I think back, my trip down memory lane really starts with that 2003 landmark report, Who Will Keep the Public Healthy, from the Institute of Medicine. And I think Ron and I, if I can remember, Ron, you and I were both testifying at that to the committee around that time. And there were many important things, I think, historically that still drive professional preparation and training today. But one of the ones that stood out to me and germane for our discussion is that the IOM recommended that schools and programs of public health should strengthen their faculty development in policy advocacy and be rewarded for engaging in policy-related activities and be at the table in important policy discussions to advance the public's health. So that's a background. Next slide. And with that foundation, about a decade later, we had that first Essential Public Health Services published. And then more recently in 2020, a major update to the framework that calls on public health professionals to create, champion, and implement policy plans and laws that impact health. And we know that those policy advocacy skills are crucial for eliminating health disparities and advancing health equity. Next slide. Then the council took that framework one step further in 2021 and issued updated workforce competencies that further articulated advocacy and its components, such as advocating for a diverse, inclusive, and competent workforce, and as well as advocating for health equity and environmental and social justice. Next slide. In harmony with these essential services, we have several certifications that have become really very important in our training. And advocacy is included as a core area of responsibility for the Certified in Public Health certification, as well as 2 certifications for health education specialists, the entry and the advanced level. And these identify advocacy skills, and they're used both by professional preparation and the workforce continuing education providers, such as SOFI. And we are now in our 26th year of offering our Health Education Advocacy Summit, which will take place in the fall this year. So advocacy is a core area of responsibility of health educators, and we do our best to train both faculty and students, as well as practitioners, in advocacy skills, knowledge, attitudes, and skills. Next slide. It's also very important to acknowledge the important roles that the Council on Education for Public Health has provided us, and since 2016 has articulated the important area of students should know how to advocate for political, social, and economic policies and programs that will improve the health in diverse populations. And they go on to say it refers to the ability to influence policy and decision-making, such as through stakeholder mobilization and educating policymakers. One of the other things I find very interesting, it gives guidance as to say, it's not just about sufficient to have students engage in a debate around a policy issue, but they should be involved in developing something that would be useful in an advocacy campaign or effort, such as legislative testimony, fact sheets, advocacy strategy outlines, etc. Next slide. And then, just hot off the presses last month, some of you may be familiar with the new WHO workforce report. They issued the National Workforce Capacity for Essential Public Health Functions. And there were 4 different documents in this, which include the Competency and Outcomes Framework for the Essential Public Health Functions, and specifying stewardship of governing of laws and regulations, with the sub-functions clearly calling for the role of public health professionals in advocacy. So we're not only grounded on these activities in the US, but this has become a more global and important initiative for us in addressing health equity and eliminating health disparities, advancing the public's health, both in the US and a global scale. And I'll drop that in the chat for you in a few minutes if you haven't seen that report. Next slide. So I think with that background, and just to summarize, we've seen many different voices in the choir that have been calling for the essential role of public health professionals, all public health professionals in advocacy, and especially highlighting this area since COVID, I think has really exacerbated and stimulated more attention to this. But what we seem to be lacking is the important role of harmony in bringing all of us together so that we can all sing from the same basic song sheet and give us a framework for getting us there. And that's why I'm excited to be involved with the FACT initiative, because I see it as something that, even though we've been talking this game for a long time, we've still, as a profession, public health profession, haven't fully embraced the opportunity to bring faculty, students, and practitioners all singing from the same song sheet. So with that, I'm going to turn it over to my colleague, Megan Ames from the Hopkins Learner Center for Advocacy, which is supporting the initiative and has a variety of great resources to share with us today. Megan?
Awesome. Thank you so much, Elaine. I'm so happy to be here. We're very excited about this project. The Learner Center is a small center within the Bloomberg School of Public Health at Johns Hopkins, and we're serving as the coordinating body for this effort that you're going to hear more about. But we're just coordinating, right? So there's lots of hands, lots of individuals like Elaine and other organizations that you'll hear about. But I just wanted to give you a little bit of background on the Learner Center. So if you could please go to the next slide. I've included our mission statement here. We really were developed to try and bring advocacy into public health at the academic level. And we do focus on that through communication, policy engagement, and other advocacy activities. Next slide, please. Here's the working definition of advocacy that we use: strategic actions taken to drive social, organizational, or policy change on behalf of specific health goals or population health. It's always helpful to kind of know where you're starting from. Next slide. And this has been a part of the university and the School of Public Health's commitment over the past few years. So here I just wanted to highlight that it's part of our strategic plan at the School of Public Health, and it's also incorporated into the university's 10-for-1 strategic plan. So this is something that Johns Hopkins is really committed to, and we'd like to lead other communities and universities to do that also. Next slide, please. So this comes from a paper that was published just earlier this year in Public Health and Management Practice. And it's basically pulling from those Council on Linkages core competencies for public health professionals and identifying how advocacy is embedded in each and every one of those. Elaine already presented how important it is to public health, so I won't harp on that, but this is certainly important information. And next slide, please. I'm just going to provide a quick overview of some of our educational efforts, just so you know what else we're working on before I pass it on to Glenn. Next slide. Certainly, our students are a key stakeholder in our institution. And so we do have a variety of courses that focus on advocacy, and we do have a public health advocacy certificate program. Of note, this health advocacy course actually reaches over 300 students a year at the Bloomberg School of Public Health. And so we have the goal of trying to reach all of our MPH students with advocacy training because it's so essential. Next slide, please. For professionals, we actually just earlier this month launched our very first ever Advocacy Action Lab. This was focused on faculty and staff at the university, but we're hoping to expand it to other audiences moving forward. We also recognize great advocacy work within academia through our Somer-Clag Advocacy Impact and Achievement Awards. Next slide. And we recognize that advocates are everywhere, right? And so we have instructional videos, resource libraries. Our director has recently published a book, and we have all of these resources on our website. And so I hope you will check them out because they're very useful. We have a video on how to submit effective public comments and deliver testimony. We're working on some more this summer also. Next slide, please. And particularly relevant to what we're here to talk about today is how we can help our educators really bring advocacy into the classroom and prepare our next generation of public health professionals. And so earlier, I think it was last year, we delivered a webinar along with CEF on teaching advocacy to public health students. And then this year, we are launching the Public Health Advocacy Consensus Task Force, which is what we're going to be talking about next. So here is, next slide, please. Here are some ways you can get in touch with us. I hope you will consider signing up for our newsletter, where you can learn about more of the different things I just mentioned about, including this FACT project. I'll also put the link in the chat. And so at this point, I'm really excited to introduce Glenn Schneider to discuss more about the PH ACT project. So thanks so much.
Great. Thanks, Megan. Thanks, Elaine. Thanks, Ron. Thanks, Dr. Keck. Thanks, all of you who have come. To say I'm a little bit excited about being here today is probably an understatement. I've been excited about this for a while, ever since we had the opportunity to come and talk to you. Thank you so much for allowing us to talk about this important project. I'm going to tell you a little bit more about FACT, a little bit more about myself towards the end of this, but I wanted to kind of build the case for what Elaine started and Megan continued. Next slide. And even Ron kind of got us started with this sort of sense. You know, despite knowing that advocacy is so important and critical to all of our work, despite having centers like the Learner Center at Hopkins and others all across the country, we are figuring out now, there's building research that says we aren't necessarily preparing our students to be engaging in advocacy effectively. Next slide. I'm going to show you what I mean. We know from the Public Health Win survey, 45%, nearly half of all public health executives at health departments all across the country desire more training and policy engagement. That should say something by itself. Next slide. We also know from a study done in health affairs that no school of public health requires advocacy classes for MPH graduation. So despite our 2016 change to our competencies, despite the Council on Linkages change, we still haven't seen that filter down into schools and programs of public health. Next slide. And if for any of you who've seen the Network for Public Health Laws Frey report, I think this is so telling because it really does describe sort of what we have found in the literature so far, and it's that the field is skittish about advocacy. We are skittish about it, and that really means that we need to take another look at how we do this work. Next slide. So it brought up an important thing for us to look at the current state of advocacy instruction in schools and programs of public health. For those of you who'd like to play along, gave you a QR code that you can go ahead and look at while I talk about the study. I'm excited to talk about the study because it was my study. So mine and our co-authors, we took a look at 98 syllabi that were submitted to CEF in response to the competencies that we were talking about for advocacy. Next slide. What did we find? We found that most courses that are teaching advocacy are including them in survey courses. Typically survey courses or policy courses which limits the amount of advocacy content that you can include. We found that they were teaching about 2.43 skill categories, but overall, if you're looking at what we're teaching, less than half of all the syllabi that we looked at included content on these things, these skills that are typically related to success in advocacy campaigns. Next slide. So the question then is, how are we going to get from our current instructional model, which by the way, we found great variation across the country, interpretation of what advocacy means to what Ron said a second ago is really a big deal. We found that some people interpret advocacy as maybe I'll teach you how to write a letter to the editor, and others might say, I want to teach you how to do lobbying. And some might say, well, I want to talk a little bit about community organizing, but we haven't really settled about what definition that we all are comfortable with, nor the essential skills that could operationalize that. So how do we get from our current 1.0 advocacy instructional model to an advocacy 2.0 model? Next slide. Introducing FACT, Public Health Advocacy Consensus Task Force. Right now, these are the current cast of characters, if you will, the leaders here of the group, of which we hope that the Council on Linkages and perhaps even your own individual organizations will choose to become a part of, because it's together that we're going to figure out the answers to these questions. Next slide. So what are we trying to do? A little bit, I guess I want to repeat what you heard from Ron and others. We want to gain consensus on the definition of public health advocacy. You heard from Megan. She said, here's where we're starting with. It's helpful to know. And we've had a lot of different organizations say, well, here's what we think it should mean, and here's what others think it should mean. What do we all think it should mean? And what are the essential skills that would operationalize that? And once we've figured that out together, then perhaps we can draft some guidance that would be helpful to schools and programs of public health as they look to hopefully implement something across the board. Next slide. So if you personally, if this sounds exciting to you, and coming up on the big July 4th holiday here, we thought it would be great for you to take action. So if you want to take action yourself, go to this form, take a look at all the different activities that we're about to talk about and decide if you might want to be a part of this individually first. Next slide. We have so many ways of getting involved in this work. You heard from Elaine that she is a member of our advisory committee. So we have an advisory committee that is full of luminaries of the field who are pledging to give just 1 hour per quarter of time to this. So it's not going to be something that's going to be entirely burdensome, but we want to be able to ask for input along the way to make sure that we're doing the right thing. Next slide. We're also going to have a study, a Delphi study, to take a look at how we can get closer, looking at expert panels of people who teach advocacy and expert panels of people who do advocacy on a regular basis, change laws, policies, systems, budgets at the state, local, and national level. Next slide. We're going to do town hall meetings. This is something I'm so thankful to PHF. When we originally came to PHF and said, hey, will you be a part of this? They said, you're going to do town hall meetings, right? Yes, we are going to do town hall meetings because we want to hear from the field about what you all feel are barriers or enablers to us doing this sort of work well. And we've already had, through ASPPH, we had our first town hall meeting in March. We're going to follow up, next slide, with some other ones here coming up. We have one with Sophie and the PHEP, section of APHA to be a part of one in September. We're going to have one actually at APHA for all of those who are going to be there, with 4 sections co-sponsoring that. If you want to be a part of that or you want to have your own, let's talk. Next slide. We're going to do focus groups as well. So once we have some results from that study, we want to be able to take it and do a little bit more deeper dive to help us develop the actual guidance that we're going to need to share with schools and programs of public health. So we're going to do some focus groups as well. We're looking for people to participate in all of these activities. Next slide. And lastly, we're going to draft some guidance. This perhaps is, remember, anyone who signs on to this effort right now is endorsing the idea and the process. No, we don't have any guidance. We don't have any definitions at this point. Once we do, and once we've come up together like this, then we want to circulate this around to all the organizations who are a part of FACT and all the organizations who participated in some way to say, does this make sense, before we take it then further and issue those as official guidance. Next slide. So our ask of you today as the council on the whole, we are hoping that you will join that list of logos that you saw earlier. What does it mean to the field to have the Council on Linkages be a part of this? It means a lot. You all are representing the big part of what the field of public health is. If you sign on, these are the 4 things that really we're asking of you. Allow us to add your logo. Again, you're endorsing the process. There are no findings to endorse at this point at all. Designate a representative to the advisory committee. Again, 1 hour per quarter is all we're asking of that representative. Third, provide occasional feedback, either when asked or when you feel compelled. If there is something that catches your eye, you send it to us in addition. And then lastly, help promote these consensus efforts. Help us to attract the people to be a part of all of these efforts moving forward. That means social, that means newsletters, whatever it is that you work on, and being able to share the activities of FACT so that we can continue to expand the idea of real consensus in this work. Next slide. But hey, we have some ask of you as members as well. Why not, as your own particular organization, hop on board here? You become also, much like Sophie has become a key leader in here, you too, add your name to this so that we can continue to build the list of FACT endorsers, which will increase the legitimacy and the quality of the findings that we will have at the end. Next slide. Again, I want to go back, take some action yourself. If you want to do one thing today, take your own action. It's a good idea. Go ahead, hop on that. It's really simple. It takes less than 5 minutes to do that for yourself. Next slide. Finally, why am I excited? I have been an advocate for 30 years. I've worked in state and local health departments. I've run a nonprofit advocacy group. I'm now working in philanthropy in my day job. And in my faculty role at Hopkins, I'm working with the Learner Center around this. I was so excited to be a part and asked to lead this particular effort. I've taught undergrad and graduate courses in advocacy. I've done work for the public health advocacy centers all across the country. I was a preceptor for a number of organizations and individual students in those organizations. And I'm also a DRPH student at UIC in my research phase. And I'm going to let anyone guess what I'm researching. Yes, that's right. I'm researching all of this. So I'm excited to be a part of this. I think it's something that if we do this right, we're really going to change the way advocacy is done in our field. Next slide. And if you have questions at all, you can certainly reach out to me directly, certainly Elaine, certainly Megan, but also Dr. Shelley Hearn, who is the director of the Learner Center at Hopkins. She could not be with us today. She's actually abroad. And she said, please wish everybody the best here and encourage them to be a part of this. But if you have questions, reach out to any of us here today. So I'm going to hand it back to you. Thank you so very much.
Well, thank you, Glenn, Elaine, and Megan. Glenn, it's unfortunate that you're not at all passionate about this. Let's open the floor for questions and comments. And please, again, share your video if you'd like. Any thoughts about the ask in front of us? And as a reminder, the ask really is for the Council of Linkages to be listed as one of the lead organizations in helping to move this initiative forward.
Glenn, outstanding presentation with you and your colleagues there today. I'd like to ask something that typically comes up when we talk about these important initiatives, and that's timeline. Your perspective on timeline and perhaps various types of benchmarks that you're hoping to establish as an entire group.
Thank you, Dr. Gilmore. Yes, we do have a timeline and bench lines. I should have added that in there. Thank you for reminding me. So we are hoping to do this over the course of a year. It could be that we're hoping that the study takes place in the fall, concurrently with perhaps the town hall meetings, then the focus group soon after that, and then the longer process of really developing the guidance part. That's going to take a little bit longer. So focus groups and guidance probably in the spring of next year to get us to some end result later on after that. That is the hope. But of course, we'll see where this takes us. This might be something that takes us a little longer, but we are hopeful to do this in a year.
Thank you very much.
Mm-hmm.
I realized I was on mute. Other questions and comments? It's a quiet group today. You must have wowed them.
Or it's 150 degrees in their place, so they might also be hot.
Right. Well, if there are no further questions or comments, let me lay out there the next step here. It is that the Public Health Advocacy Consensus Task Force, FACT, right? Is that, or no, not, yes, FACT. Okay. Has requested the Council on Linkages sign on as a lead organization of this initiative. Again, not endorsing any particular finding, but really saying, hey, we really believe that advocacy in public health is important, and we'd like to see the education and training of public health professionals improved, if you will, in this area. And one way to start that process is defining what we mean by advocacy, identifying the competencies, et cetera. And as mentioned, this does really build on Council on Linkages work, where we do have several competencies related to advocacy. So the process here will be, we're not asking for a vote today, so don't worry about that. As we traditionally do with the Council on something like this, we'd like you to talk with your organization's leadership about this, to see if your organization's leadership is supportive of the Council on Linkages supporting this effort and being listed as one of the lead organizations. Glenn, I think also we've been asked if you would inquire about whether or not your own organization would be willing to be listed as well. Both can occur. The answer could be yes to Council. The answer could be yes to your organization. The answer could be yes to Council and no to your organization, and vice versa. So that's, any of that is fine. So we'd like that discussion to occur with your leadership, and then we will, in a couple of weeks, send out a a vote. We'll try to vote by mail, email. And if it's a yay vote, we will let Glenn et al. Know. Well, either way, we'll let Glenn et al. Know what that may be. And if there are questions that crop up, feel free to ask us as council staff. We'll pass it along. And one of the reasons to let us know is so that we can let the entire council know what a response might be to a question. I think that could be helpful. So let me see if there are any questions about the process.
Is there this David Bias here representing National Board of Public Health Examiners? Allison Foster's traveling today and not able to be with us. Is there a white paper, a one pager? I mean, we've got the link. Is there anything else that would be helpful for us to pass along? And maybe if you've already said that and I missed it, please excuse me. But if there's something that we could send along, you know, that's a kind of TLDR sort of document, that'd be helpful.
Yes, so we can send you a whole bunch of different things, but start with the website. The website's pretty small and concise.
Okay.
It kind of lists all the things there. If there's something that you need beyond that, we're happy to provide it for you.
Okay. Sounds
So
great.
just let me know. Just reach out to me. I'm happy to give you whatever you need.
Perfect.
And then, of course, if there is a yes vote, then a council, we would be looking for a council linkages member to volunteer to be on the advisory council as well.
Mhm.
But that's another step in the process. Any other questions or comments? Well, we really appreciate your participation today. This did, in my view, fit very well with rebuilding the public health workforce as our continued agenda item for all of our meetings. And we know whether things go smoothly or not in the future for public health, we know that advocacy is key. It's key to our support from the standpoint of even just the verbal support of the public officials and others. Financial support, of course, is key. We know the public health infrastructure grants are out there, but there's nothing in there sustaining them necessarily. Well, what is a way to help get those the funds sustained for public health? Advocacy is a piece of that. And just advocating even for things like childhood immunizations within our communities. So with that, let me turn it back over to Dr. Keck. Thank you again, Glenn and Elaine and Megan.
Thank you all.
Thank you for having us.
Indeed, I'll add my thanks to those of Ron, to the presenters. That was clear. I think the absence of questions is an indication of how clear and straightforward the request is. I'm not anticipating any difficulties here. We shall see. Well, moving on then to our next agenda item, which is a presentation on resources for using the Applied Epidemiology Competencies. In 2023, the Council of State and Territorial Epidemiologists updated the Applied Epidemiology Competencies to align with the 2021 revision of the Core Competencies for Public Health Professionals. To support implementation of this competency set and others, the group has recently released a new Applied Epidemiology Competencies toolkit and trainings. So I'd like to introduce Sarah Auer, who's the program analyst from the Council of State and Territorial Epidemiologists, to share information on these new resources for the field. Well, Sarah, the floor is yours.
Awesome. Thank you so much. And thank you everybody for having me today. Like I was introduced, my name is Sarah Auer and I'm an analyst at CSTE and had the pleasure of leading our revisions to our Applied Epi Competencies, as well as the creation of our toolkit and trainings that I'm going to share with you today. Next slide, please. So my goals for speaking with you today is to provide an overview of our recently released toolkit and trainings and provide a couple of use case scenarios for using these materials. Next slide, please. So as mentioned, CSTE recently revised our applied epidemiology competencies. We went through a comprehensive process of town hall meetings and really hearing from the field. The Public Health Foundation was a wonderful collaborator in that, and we made sure that ours align with the core competencies for public health professionals to ensure that they can be used together. And our full report of our competencies can be found from our webpage, but we did release them last spring in 2023, and since then have been working on some materials to support them. Next slide. So after we released them last spring, we knew that many would be wondering, the competencies exist now, but how do I implement them into my organization? How do I make them actionable? How do I use them? Next slide. So I'm going to give you a couple of scenarios where what we've created would be helpful. So imagine that you're revising your curriculum for your university's epidemiology concentration, and you really want to ensure that your graduates have the skills they need to succeed in governmental public health. But this is no small undertaking, and you might be wondering, where do I start with this process? What do I need to be sure to include when I'm doing it, and who should I consult? Next slide. So as part of our toolkit, we created a crosswalk with the CEF accreditation standards. So it's a comprehensive crosswalk with the MPH and DRPH foundational curriculum. It exists in a very easy to search and sortable Excel document. And it's an excellent starting point to really align accreditation standards with the skills needed in the field. Because part of what we realized as we were creating the competencies and as we run other things like our EPI capacity assessment is really wanting to ensure that we provide resources to academic institutions so that their graduates are ready when they enter the field. Next slide. Now imagine that you have epidemiology students and you really want to understand their current skill sets, whether that's understanding as they enter the program or right before they graduate, because you want to be able to better prepare them for life after graduation. But you might be wondering, how do I capture that information? What do I measure? And again, where do I start? Next slide. So when we first created our competencies, we released evaluation tools in the form of PDF format, but we found that they were cumbersome and very difficult to navigate. So we've created an online interactive version. And with this assessment, you're able to self-assess. So see what your knowledge, skills, and abilities are in the competencies, or assess somebody else, so somebody you might be supervising. It also provides an opportunity at organizational level data. So this applies to both health departments or academic institutions. They can request and students or folks in a health department can consent to having their data shared out so that their organization can look at data from the organizational level. It's very useful for determining knowledge gaps in planning, training, and education. And we've tried to make it as user-friendly as possible. So in each domain, you can choose a different tier depending on where you're at. And at the end, you get a comprehensive score report. Next slide, please. And finally, in this instance, you want an easy and accessible way for your staff to understand what the competencies are. What are the applied epidemiology competencies and how do I implement them? And again, you might be wondering, where do I start and who should I consult? Next slide, please. And to alleviate that, we've created 2 courses, but this one in particular is our Introduction to the Applied Epi Competencies. It's an online asynchronous course, and it provides a comprehensive tutorial on the competencies and how to use them in an organization. These are free on CST Learn, which is our learning management system. You do not have to be a CST member. It's open to all. You just need to create a login. But this is a really great way to provide an overview of what the competencies are and how they can be a useful resource in your department. And it aligns very well with all the toolkit materials that we've created. Next slide. So I've touched on a couple of pieces that we've put in our toolkit, but this is a more comprehensive overview. So I've divided it up into 3 sort of spaces, but all of these things live together on one website, which I'll show you momentarily. But our toolkit includes worksheets for creating competency-based job descriptions. So that's step-by-step to walk you through exactly how to do that. Career portfolios, which is sort of a newer version of a career ladder. Creating things like training plans, including a fillable resource. We've also created interview questions for the 4 tiers of epidemiologists that you'll find in our competency set, so that when folks are doing that, whether they're preparing graduates or working in health departments, they really have a strong set of scenario-based questions to draw from. And then we have that crosswalk with the C4 accreditation standards. I do want to note that while these were created in alignment with our competency set, these worksheets can be useful for any competency set. It really hones in on the entire process and is a step-by-step instructional worksheet. And really guides you through how to do these things, whether that's creating equitable interviews or creating training plans that really work well for your staff. We've also created these 2 course trainings. So I touched on the intro to Applied Epi Competencies, but we also have a training on using the Applied Epi Competencies specifically for recruitment and retention of epidemiologists. And I think that one's really useful as it aligns again with those toolkit worksheets, but really hones in on how competencies can be useful for obtaining the correct staff members, but also keeping them long term. And then we have those online evaluation tools, which include that self-evaluation and that supervisor evaluation. Next slide. So all of these resources live in one place, and that's cste.aecs.org. That is where you can take those online evaluations. All of those resources are linked and downloadable for your use. We've also made them editable in PDF form, as well as a link to our main competency set. Next slide. So in thinking about all of these resources that I've talked about, there are a lot of ways to apply them in the field. Again, they can be very helpful in recruiting and retaining efforts in health departments. They can ensure that we're aligning curricula to prepare students for careers in applied epidemiology, because these competencies and the toolkit materials are really focused on what we heard from EPIs working in health departments and what they think current EPIs and new EPIs need to succeed. We think of the toolkit as a way of making the competencies easy and accessible to use. We've tried, just like we did with the competencies, to make the toolkit materials very accessible and step-by-step. And it also, in creating those evaluation tools, provides ways to self-evaluate and evaluate others and their knowledge, skills, and abilities in the competencies, which we know can be very useful from students to those working in health departments. Next slide. So what are our next steps? This week we are hosting a webinar, Putting the Applied Epidemiology Competencies into Practice, and this will feature lessons learned from schools of public health that have incorporated the competencies, as well as public health jurisdictions, and that link will be in the chat. But if you're already using our competencies, or you have requests for our toolkit, we'd love to hear from you. So we do have a feedback form that will also be in the chat. And we'd love to hear not only what you're doing, but what would be helpful for you. Additionally, we're always happy to come and speak about the competencies, whether that's to talk to your faculty or your staff. So please reach out to us at wfresources@cste.org if you'd like us to come speak about them, and we're happy to do that. Next slide. I'm so happy to answer any questions today, but if you have any additional questions, please feel free to reach out to us at that email address on the slide here. And just want to thank everybody for having us today, and to the Council and the Public Health Foundation for always being a wonderful collaborator as we roll these things out.
Terrific, Sarah. Thank you so much. Let me open the floor now to questions for Sarah. Any questions or comments?
Sarah, hi. I appreciated your overview, and I thought it was very helpful. And I appreciate, too, being a public health epidemiologist for now going on over 50 years. I appreciate that this is being done. I wanted to treble underscore that. In other words, emphasize it. But my question is, with competencies, as we're all aware, there are different levels of competencies. And I'm wondering if this is particularly related to more introductory level, base level competencies, or if either now or in the future, they're going to be scaled, because I see this being a rich resource, not only as a starting point, but as a continuing resource.
Yeah, thank you so much for the kind words and the question. So our competencies do include 4 tiers. So they scale from foundational to advanced. We have foundational, intermediate, practice, and advanced. And in creating the toolkit materials, a lot of them have a version for each tier. So our career portfolios have a specific document for if you're moving from one tier to the next. Our interview questions are by tier. So we've really tried to provide resources, which you're exactly right, that are great for introductory EPIs, but also can help all the way up that scale, so that we're providing resources, like I said, not only for recruiting epidemiologists, but retaining them and giving them professional development tools.
Perfect. Thank you.
Of course.
Other questions? Sarah, the presentation must have been very clear and straightforward. Thank you so much for coming and sharing with us the progress you've made. Just to remember, all of you on the council, that from the beginning of the core competency process, we've always seen the core competencies as sort of foundational, but have encouraged groups with special interests or special skills to use them as a base and develop their own competencies as well. And this is a wonderful example of that being done. Thank you so much. Well, with that, then we can go on to our next agenda item. We have a series here of presentations to bring you up to date on current council activities. I'm going to ask Grace Davis to give us an update on the academic health department learning community. And Grace, the floor is yours.
Thank you so much, Dr. Keck. So I'm Grace Davis. I'm a project associate at PHF and provide some staffing for the council. And I have a few updates on recent activities of the academic health department learning community. So the AHD learning community is a national community that brings together and supports practitioners, educators, researchers, and others to explore AHD partnerships, which we define as formal partnerships between health departments and academic institutions. The community is designed for members to share their experiences and engage in collaborative learning with each other. The AHD learning community is open to anyone who would like to participate and currently has more than 1,500 members from health departments, academic institutions, and other organizations across the country. The learning community also offers resources and activities to those members and others in the public health community to help support AHD partnerships. So this includes providing a venue for sharing examples and stories, webinars featuring AHD partnerships, examples of agreements that organizations have used to formalize their partnerships, a listserv to enable communication among community members, as well as technical assistance. So as we've done for many years, we continue to track metrics related to engagement with the AHD learning community and its resources. The learning community and its resources and tools have been accessed online more than 1,400 times since our last council meeting in March. This brings online usage of the community and resources to more than 87,000 visits since their launch in 2011. We also continue to provide distance-based technical assistance related to AHD partnerships. And again, since the last council meeting, council staff have responded to 6 different requests serving 6 organizations in 6 states, and you can see the map on the screen. Our presence at conferences and webinars has also continued. We've done a lot in the past couple months. So we held our latest webinar in our AHD webinar series in April as a part of National Public Health Week. This webinar, entitled "The Public Health Camp, Building an Academic to Practice Pipeline at Public Health Seattle and King County," featured guest speakers from an academic health department who shared their experiences working to establish their partnership, and also a specific initiative called their Public Health Camp. Earlier in June, AHD partnerships were also featured at the Public Health Improvement Training in a town hall session titled "Strengthening Linkages Between Academia and Public Health Practice," and in an association of state and territorial health officials workforce pop-up webinar. Later this year, we plan to highlight AHD partnerships at the 2024 Public Health Learning Forum in a session enhancing capacity through academic health department partnerships, and also in the American Public Health Association annual meeting. So we'll have a session there titled Bridging the Gap Between Workforce and Communities, the Role of Academic Health Department Partnerships in Advancing Diversity, Equity, Inclusion, and Justice. So we look forward to those presentations both in October later this year. In addition, we're excited to say that CDC has invited council staff to present a seminar for CDC staff on AHD partnerships, which will take place in September. This seminar will feature speakers from state and local public health. So we'll have Antonia Blinn and Chrissy Bellick from the Massachusetts Department of Public Health, and Sarah Worthington and Nicole Miller from the Toledo-Lucas County Health Department in Ohio. And they will highlight those organizations' successful partnerships. We're also in the process of planning our next AHD webinars. So as we have more information about those, that will be made available through the Council on Linkages update. Does anyone have any questions about the AHD learning community or recent initiatives? And as always, more information about the learning community and its activities will be available through the council website, or you can always contact Myla or myself to ask any questions. Fantastic. Well, with that, we'll move on to some updates about another council initiative, the Core Competencies for Public Health Professionals. So you can go to the next slide, Myla. Thank you. So the core competencies are a set of competencies designed to reflect foundational or cross-cutting knowledge and skills for all public health professionals, whether engaged in practice, education, or research. Like Dr. Keck said earlier, the core competencies have been around for more than 20 years, so since 2001, and have gone through several iterations, the current version being adopted by the Council in October of 2021. These competencies are used in workforce development activities across the country. So the most current data that we have available show that approximately 80% of state health departments, 60% of tribal health organizations, 55% of local health departments, 25% of territorial health departments, and 90% of academic programs with a public health focus use the core competencies. And that the competencies are also being used in a variety of ways, including to guide the development of job descriptions and performance objectives, competency training or needs assessments, education and training, workforce development plans, other specific competency sets like the AECs that Sarah just talked about, and other tools and resources to support professional development for professionals. The core competencies also appear in major national initiatives such as Healthy People and accreditation. So Healthy People 2030 includes objectives in the public health infrastructure topic area related to increasing the proportion of state, local, tribal, and territorial public health agencies that use core competencies in their continuing education for personnel. The Public Health Accreditation Board, in its accreditation standards for health departments, incorporated the core competencies into Domain 8 of the Standards and Measures for Accreditation, specifically Standard 8.2, which addresses workforce development and requires the creation of a workforce development plan that includes an assessment of current staff capabilities against an accepted set of core competencies. So the core competencies are given as an example of a nationally recognized model that may be used to fulfill that criteria. The workforce development plan should also include findings from an equity assessment that considers staff competence in the areas of cultural humility, diversity, or inclusion. This equity assessment could be one component of the broader core competencies assessment. For schools and programs of public health, the Council on Education for Public Health used the core competencies in developing foundational competencies for its accreditation criteria. And the core competencies are also integrated into the Train Learning Network, which is the largest learning network designed specifically for public health professionals, so learners can locate courses that will build desired knowledge and skills. Finally, the core competencies have long been designed to reflect the knowledge and skills needed to deliver the 10 essential public health services. Looking at the specifics of usage, since our last council meeting in March, the core competencies and related resources and tools have been accessed over 9,000 times online. We also have been tracking access of the core competencies specifically since the release of the 2021 version. And this iteration's numbers bring us to over 177,000 visits to that resource webpage since the 2021 release. As with the AHD learning community, council staff regularly respond to requests for assistance related to the core competencies. In the same time period since our last meeting, we have responded to 5 different requests serving 4 organizations in 3 states as well as the United Kingdom. So in terms of webinars and conferences, the core competencies were recently highlighted in a PHF webinar titled Using the Core Competencies for Public Health Professionals to Support Workforce Development. The May webinar featured speakers we actually saw at our last council meeting from the Missouri Department of Health and Senior Services and the City of Milwaukee Health Department, who spoke about using the core competencies to assess their workforce, identify gaps in knowledge, skills, and abilities, and also to address those gaps through training and other workforce development opportunities. Additionally, we've maintained a presence at national conferences, most recently at the Public Health Improvement Training. The core competencies were highlighted in a workshop session titled Designing a Workforce Development Plan that Closes the Gap on Priority Competencies. We're also in the process of planning sessions that highlight the use of the core competencies in workforce development planning for the 2024 Public Health Learning Forum taking place in October. We were also notified of several accepted abstracts for the APHA annual meeting, one of which will be on using the core competencies to better prepare for a career in public health. So as mentioned, the 2021 core competencies were adopted in October of that year, and they have been available through the council website since November of that year. Since that time, we've been engaged in a variety of dissemination activities to try to ensure that the public health community is aware of and has access to this latest version to participate in its workforce development efforts. We've also continued to work on updating, developing resources and tools that support individuals and organizations in using the core competencies. So we're very excited about a new resource that describes the relationship between the core competencies, 10 essential public health services, and foundational public health services that was recently developed and released. This brief resource highlights the core competencies as underlying organizations' abilities to deliver the essential public health services and foundational public health services. So along with other tools related to the core competencies, this resource is available on the council website and can be found on the updated core competencies tools page. I'll also put it in the chat so everyone can take a look at it. Does anyone have any questions about the competencies or any of our recent activities? Well, thank you so much. And if anyone has questions, again, please feel free to reach out to council staff and we would be happy to talk to you.
Thank you so much, Grace. Thank you very much. You remember at our meeting in March, one of the things we did was decide to get involved in a new retention and recruitment learning community, and Mayala Arana is here to bring us up to date on what's happened since then.
Great, thank you so much, Dr. Keck. I'm Mayala Arana. I'm a senior program manager in the Workforce Development Unit, and I'm engaged with all the Council Linkages activities. And I'm excited to share an update about the retention and recruitment learning community that we all voted on establishing back in March. So just as a reminder, and as approved at the last council meeting, we are establishing a retention and recruitment learning community to help meet the needs that we've been hearing from our partners and from others in the field. To further define what this initiative will look like, we drafted a purpose statement for the learning community. The learning community will help to foster collaboration and provide an environment for sharing effective strategies for retention and recruitment, as well as highlighting successes and working through common challenges. So building on previous council work, this is just another avenue for the council to help support health departments and other public health agencies in meeting their workforce needs. We are in the midst of planning for the learning community and anticipate the group will focus on strategies and solutions related to these 5 areas. So organizational culture, workplace environment, and employee experience. These are things that focus on creating a great workforce that is known for its mission and being people-centered. We also want to focus on professional development and opportunities for staff growth within the organization. Human resources, policies, and processes. So these are the things besides salary that make a big difference in the day-to-day for all employees. We also wanted to make the connection between the academic health department partnership work that we've done so far and how those connections can help strengthen organizational capacity, as well as supporting pathways into governmental public health. And lastly, workforce pathways and recruitment. So when recruiting new employees, what the candidate experience can look like, and innovative recruitment strategies. One thing you'll notice that we discussed back in March was that issues relating to salary, advocacy, increased federal funding, and civil service were not included on this list. We really wanted to focus and provide tools and resources that are practical and allow health departments to take action to address retention and recruitment. And those issues like salary and civil service are often outside of the purview of the agencies that we are providing support for. To guide the development of the new learning community, we have established a retention and recruitment work group. The work group is chaired by Terry Brandenburg, NACCHO's representative to the council, and includes over 60 volunteers from health departments and partner organizations across the country. The goal of this collaborative effort is to further refine the purpose of the learning community, ensuring alignment with the needs of the field, and hopefully maximizing the benefits of the learning community. So the work group is really playing a vital role in shaping the learning community's activities and future impact. Work group members are asked to review materials, help provide input, contribute their own insights, and shape the format and content that is going to be addressed as the learning community's needs evolves. So I'm excited to share that the retention and recruitment work group has met twice so far this year and will meet at least one more time. In May, we introduced work group members to the purpose of the learning community, the charge of the work group, and what was being asked of work group members. We also had some initial discussion of the suggested topic areas and potential partners for the initiative. In our June meeting, just a couple of weeks ago, the discussion focused on the audience, who we would like to participate in the learning community, as well as ideas on promotion of the learning community and further discussion of what the goals of the learning community will be. The work group will meet again on July 2nd to begin prioritizing the focus areas and to share additional resources that might be helpful. And all of this input is feeding into planning for the very first learning community meeting, which we are hoping to hold in September. So while the learning community is still under development, we have been highlighting retention and recruitment tools and resources at national conferences. In May and June, we gave a presentation on retention and recruitment in governmental public health at the Public Health Improvement Training that was held in New Orleans and repeated again virtually. We are also in the process of planning a session for the American Public Health Association annual meeting and expo, which will take place in Minneapolis in October. At this time, I'd like to ask for any questions about the retention and recruitment learning community.
Dale, a question for you has to do with that APHA meeting and the activity that will go on at that time regarding the learning community. And I'm wondering if a date has been set or a day during that APHA meeting so that we can get that on our calendars.
Yes, so it is going to be on that Sunday. I believe the time has not been decided yet, but it's going to be that Sunday, October, I want to say it's the 28th, but let me look at a calendar.
No, I was just looking at the calendar as well. It is on Sunday. and Sunday is
The
the 27th. And we believe it's going to be at 2:30, from 2:30 to 4 p.m.
Excellent choice of day and time. Thank you so much.
We have APHA to thank for that one. They kindly, several years ago, offered us a standing meeting time that day and time. So we really appreciate that. It's nice to be able to do that every year.
Yeah, perfect. Thank you.
Mhm. Maella and Kathleen, Ron, I wonder, once we have some secure dates and times for other things at APHA, can we share that with the council at large? As soon as we can. So as Gary says, we can get it on our calendars early. APHA, of course, is a very busy time, and most of us will be pulled in many directions. So that would be great if you could do that.
Yeah, we can absolutely do that.
All right, thank you.
Yeah.
Any other questions for Maella? So things are beginning to happen. Thank you all. Terry, thank you for your work on this as well. Looks like we're going to have another very interesting activity from the council.
And as
Great.
always, more information about the learning community and the work group can be found on the retention and recruitment learning community section of the council website. And you can always feel free to send me an email. So thank you.
Yeah. Very good. Thank you. Well, with that, Ron, it's a leadership change time. And so we'll turn the floor over to you. But thanks to all our presenters. By the way, we are amazingly on time. So that's good. So Ron, the floor is yours.
Always, Bill, you run a tight meeting.
No,
Yep.
People have really been cognizant of the time and done very well.
Yep.
Thank you all.
Well, everybody, as you know, Dr. Keck has long served as chair of the Council on Linkages and recently decided it's time to step back. I don't know, Bill, after just a year or two or 26, it's time to step back. Okay. So we held an election, and we have a new chair who will be chairing the next Council on Linkages meeting. And that new chair is Dr. Amy Lee. And Dr. Lee, we congratulate you. We're excited for you to be chair. We thank you for stepping in. And Amy represents the Association of Prevention, Teaching, and Research on the council, and also is the co-chair of the Council on Linkages Core Competencies work group. 10 years, we found out today looking at the record. So Amy, thank you so much for your contributions. It's great. You only have tiny shoes to fill with.
No. They're large shoes, and I can't guarantee I'm going to stay for 26 years. But I'm going to try my best to at least moderate the meetings and chair as best as I possibly can. Thank you so much.
Thank you. And so Bill will continue to serve for the time being as representative to the council for the American Public Health Association. And actually, Bill, you being on the council, I think, is one of the reasons we always have that slot at APHA. So it's been quite valuable. We are very sad to see Bill stepping down. And we are really, really grateful for all of the service you have provided over the years. We'll have time in a little bit for celebrating your contribution. But first, we want to take a few minutes to address some of the loose ends that came out during the voting process. During the process, the ideas of establishing term limits for the position of chair and creating a chair-elect position were raised. We've discussed these ideas from time to time over the years and want to make space for discussion today as well. As some context for our discussion today, the council's been operating for 32 years now, currently funded by CDC, and is a project of the Public Health Foundation. The council chair is elected for every 2 years, and the chair serves for a 2-year term. So we have elections every 2 years. During the 32 years the council's been in existence, we've had 5 chairs, and we've not had term limits, and we've not had a chair elect for those for that position as well. When the council chair is absent, which is always rare, the council meetings and other council activities are, because council activities are chair. I can't even speak today. See, Bill, you've got me all tongue-tied here.
I think you're doing that to yourself, Ron.
I know. We plan around the council chair. And on the rare occasions where the chair is unavailable, the council director, me, steps in and facilitates the meeting, or it can be done by the assistant chair, Kathleen, not chair, assistant director. I'll get this straight eventually.
Mm-hmm.
So there are some important considerations that I'd like to also note about the chair specifically. With only a couple of exceptions over the years, council members come and go, and we know that council members are selected by their organizations they represent and are expected to commit to just a 1-year term. That's a minimum, but some organizations do switch out the members fairly often. Given that the term of chair is 2 years, someone could be elected as chair-elect and leave the council before they ever would be eligible to serve as chair. That's one consideration that's always been out there in the past when we've had these discussions. Also, there are specific requirements for somebody to serve as chair, particularly the requirement to have been a public health practitioner, and that limits the number of people who can actually serve as chair in the council. So having term limits could create some problems in finding a chair at times as well. And in addition, over the years, typically only one person is nominated whenever there is a call for nominations for chair. So if you're looking for details about the process, about the responsibilities, about the length of service, et cetera, you can look at the Council on Linkages, Constitution and Bylaws. If we were to make a change in terms of there being a chair-elect or there being term limits or both, that would require an amendment to the Constitution and Bylaws, and that amendment would require a 2/3 supermajority vote in order to pass. So let me ask first off if there are questions, given how I kept on tripping over my own words there. If there are questions that people would like some clarification on, and also we'd like to have some discussion about this. As always, we want to be respectful to council members when they bring up an idea, and we want to have this conversation today. So the floor is open to all council members for the discussion.
So, Ron, thank you for that overview, and you articulated beautifully the essence of the parameters. I'm a believer in chair-elect as a position because it really can be helpful, not only during times when there might be some ongoing need, but particularly so that an individual can really pay close attention to the excellent work that is provided and has been provided by Dr. Keck over the years. And I think chair-elect positions, at least with national and state level organizations that I've been a part of, have really been helpful so that there's not a void, but rather an even transition at appointed periods of time. And so just born out of experiences that I've had, I think it is a worthy position of consideration for the council. Thank you.
Thank you, Gary. Other comments, other suggestions? Terry.
Yeah, well, thank you, Ron. I guess I have to disagree with my fellow Wisconsin representative here in terms of moving on first. Ron, thanks again for kind of the reality check on transitions of members on the council. You know, the representation, the representative organizations. Although we've had some very long-standing members. I guess in my time on the council, I have seen, new faces come and go. And if we go to a chair-elect model, we're basically asking individuals for a 4-year commitment. 2 years as chair-elect, and then 2 years as the chair. And indeed, change occurs, and they may not be available when it comes time to, become a chair or even finish their chair-elect position. So I think that in itself is problematic. And plus, by going through this proposed model, the chair, it's a one and done. You're basically saying you will serve one term and one term only, and there's no opportunity for seeking a second term unless you go back in the line again and start through the chair-elect process. I really don't see how this is going to benefit the organization. I think instead of continuity, I think it'll be just the opposite because of that long 4-year commitment that we would ask an individual to make.
Thank you, Terry, for expressing your views on it. Others? We've now had two slightly different, well, not slightly, two different. Oh, I see, John, you have your hand up.
Yeah, hi, everyone. Thanks. I guess I'm in Gary's camp of thinking that it's important for groups like this to have both consistency and sort of fresh leadership. And I think that allows for increased diversity of thoughts and of the group. So I guess I'm not overly concerned about folks who might not be able to fully carry through, because one can appoint another. You can have rules for how to fill a vacant position. I know a lot of us on our national boards end up running into that. ASCO has that challenge at times. There's multiple sort of officer positions, including sort of the past chair. And we may want to think about including the past chair as an official role for another year or something, so that you can always benefit from those. But I think having a deeper bench in the leadership serves an organization well, and can sort of bring more sort of diversity of thoughts and opinions to a group. So I think I would support taking a look at what that might be. And again, fully acknowledging the amazing leadership we've had for years here. But I think it's highly unusual to have that kind of structure in these organizations. So that's my thought.
Great, thank you, John. And John, did I hear you say that state health officials like transition occasionally?
Oh, occasionally they do.
Just occasionally, right? I think we had Joe Cantor, the new ASTO CEO, at the recent Public Health Foundation board meeting, and I think he said that we're now talking about transitions that are occurring in months, not in years. That it's become worse rather than better at this point in terms of state health officials. Other views, other comments, other thoughts?
Well, Ron, perhaps I should put my own 2 cents in here. In pragmatic terms, the reality has been that every 2 years, we have reviewed the council membership to try to identify people who would be eligible to be chair. And on most occasions, there's only been 1 or 2. Which is kind of surprising given our organization, but it appears that many of our members really don't have public health practice experience of any significance. That makes it pragmatically difficult if that trend continues looking ahead to consider having multiple people switching in and out of this role in one way or another. I suppose, though, if the feeling of the group is to go with a 2-person leadership, well, I really don't think that's necessary here, because every 2 years you can change leadership if you wish, or sooner, certainly if the council decided it wasn't happy with the current chair. But rather than a chair-elect, it might consider a vice chair. So that you didn't have that sense that the chair-elect was going to automatically then move into the chair's position. But it could very well be that there would only be 2 people on the council who would be eligible for that slot. So at least in our experience, it hasn't been a problem. So in a sense, it's might be a solution looking for a problem. There hasn't been a problem there. But of course, what John and Gary have said is certainly accurate. If you wanted to have more diversity in terms of the leadership in thought and background and experience, then of course you shouldn't just keep electing the same person every 2 years. But having 2 people might give you that backup, and then the option every 2 years, depending on the interests of the people involved, to either continue with that relationship or do something different.
Other thoughts? So you put on the table there a vice chair versus necessarily a chair-elect. The vice chair, I guess, could serve sort of in both, almost both functions, and be elected as chair rather than just automatically becoming chair.
Yes.
Mm-hmm.
Other thoughts?
May I add a thought?
Sure.
I'm not sure if I'm allowed to have a thought here or not, but and I don't know, Ron, if you said this as you were stumbling over all those words. I can't remember. But what you just said, Bill, also makes me think about the fact that while we only have we have a chair of the council, each of the council's initiatives has a chair, sometimes co-chairs. So each area in which the council is actively working has leadership that's separate, if you will, from the chair of the council overall. It all feeds together. But there might be some ways we could look at that structure as well. We have traditionally, at times, those chairs have had larger roles or smaller roles, depending on how much work is happening in those areas. But that might be something that can provide a deeper bench, if you will, in terms of the leadership structure that's sort of built into the way the council operates already. Like, I don't think we'd need to change bylaws necessarily to formalize that a little bit more or think about how we want to use that. But that's just a random thought.
Yeah, Kathleen, thank you for raising that. I had meant to mention that, but had not.
Cool. Right. So I wasn't just ignoring you, is what you're saying.
Right. So yeah, our newest chair of a work group, as mentioned earlier, is Terry. Other thoughts, comments, suggestions? Where we may go from here And Amy, this will end up falling into your lap as chair. But I think we're going to want to put our heads together and see, maybe we would ask for a few volunteers from the council to form a little work group to talk this through and lay out, more of the pros, cons, and an actual, if we're going to look at a change like this, what the actual change would be to the Constitution and bylaws, just sort of laying out that process. Thoughts about that? Seems like more discussion.
I think that makes sense. Ron, you could certainly the group could lay out options.
Yeah.
Pros and cons for the council to consider.
That's what I'm thinking. Any concerns about that? Any other perspectives on a next step? I guess we have potentially 2 years to figure it out, but
I thought I saw Lisa Lang's hand go up. Lisa, did you have a comment? It flashed up just for like a nanosecond.
This is Lisa, and I say hello. As someone who would not be qualified under any circumstances to even attempt to the position that Bill has occupied so well and that Amy's stepping into. I think what Ron, I was actually trying to second what Ron was saying, and that maybe that the combination with Kathleen is offering, where you've got in essence a committee, a council of folks who in essence could be almost a nominating committee for a replacement to the successor, for the successor to the chair. That might be another strategy for this. But I think the idea, Ron, that you're suggesting that, there might be a little bit of thinking that could go into a proposal that would take advantage of the leadership you're both trying to grow and the continuity that you're trying to achieve. That would be a good idea. So that would be my 2 cents from the peanut gallery, but thank you.
Thank you, Lisa. Lisa, who used to be the National Library of Medicine rep to the council. Well, let me ask Gary and John if the idea of us forming a little group potentially to think this through a little bit further and have a specific proposal potentially to present to the council makes sense.
Absolutely, I'd be delighted.
Okay. So it sounds like we have one volunteer, Gary. John, you're shaking your head. Does that mean we have a second volunteer as well?
It does.
Okay. And if there are others who wish to volunteer, you can speak now, but we also will send out a note asking people if you'd like to volunteer. We're not doing any voluntolding here. And Bill, since you'll have nothing more to do, maybe we could get you to volunteer as well.
Sure. Mm-hmm. Okay. Not on those grounds, however.
Okay, so we still have a little bit of time left, and we really, Bill, we want to celebrate your service as chair. The role that you have played has been phenomenal. I know you're shaking your head, but you've been a phenomenal leader. I know I've learned a ton, and I'd rather save what I have to say till later, and I'd love to give some others an opportunity to chime in and to get things started, if I may. I'm going to my phone here because Hugh Tilson. So Hugh was one of the early people on the Council on Linkages. Hugh was involved with the council for many, many years. I don't think Hugh never served as chair, but you would never know that by the various comments that provide over the years. So Bill, here is what Hugh sent to me. He said, Bill Keck stepping down? Couldn't be. Isn't he the heart and soul of the Council on Linkages? Isn't he the rock upon which the amazing edifice rests? Isn't he the visionary who has led the campaign to extend the vision of the Faculty Agency Forum for Strong Town-Gown Relationships, including the amazing program which he delivered the academic health departments. Hasn't he been the voice for public health practice competencies, which has led the way for workforce standards and agency accreditation? Stepping down? Couldn't be. Or did I already say that? Congratulations on the amazing legacy and so much more, and best wishes from a fellow retiree. So Hugh Tilt, I had to read it exactly as Hugh wrote it because it was so Hugh.
Yeah, it is very Hugh. Who is Hugh?
Who is Hugh?
Yes.
And Hugh cannot be here because he's actually moving. And he said today the movers are moving the furniture and other things, and his internet is off, etc. Otherwise, he would have joined us today.
Oh. Wow.
So I open the floor to others who might want to wish Bill or congratulate Bill on his service. Anybody else have anything to say?
Bill, I'd like to share a moment with you. It goes back about 30 years when you were president of the CEF Council itself. And you actually were in that role with the Council on Education for Public Health in the leadership role. And there was a time when as a director, and some of the directors who may be on the call today will remember this, we would actually come in person to the discussion of our continuing accreditation related activity. And I'll be brief, but I do want to put an exclamation mark here, maybe 3, since I typically do things in 3s. But it just lives in my memory as I came as director before you and the other council members, and this is for CEF. The way you conducted those discussions with great respect for everyone in the room, including those of us who were coming before the council at that time, the kindness in your heart, and I've always seen that demonstrated, even when you were serving as a presenter in my graduate administration class, and all of the times that we have interacted. And thirdly, just like you did today with presenting different vantage points for strength in discussion, just like you did with the idea of vice chair today. You always had that thought to insert into the discussion that could guide next steps. And my friend and colleague and mentor and peer, and even with the breakfast that you came to with the graduate students who had a great desire to interact with you, that kindness, that respect for everyone in the current discussion location, along with the insertion of good and great ideas. That's how I recall you. And quite frankly, I wrote a page of commentary, but I thought I'd share this with you personally as well. Thank you, my friend.
Oh, my goodness, Gary, thank you so much. I'm embarrassed.
Well, I see a hand up, Dr. Irwin. So nice to see you.
Uh-oh.
He knows too much, is that it?
Ron, good to see you, and Kathleen, and all my friends at PHF and the council, and especially to Bill and Kathleen. Thank you for providing the link to allow us who are not currently members of the council, but who have been a part of PHF in one way or another for many years to honor this this graceful man, this man of grace. Bill, you have been my inspiration for essentially my entire career, because my career has been spent on trying to do this very thing that you wrote about with the academic health department to bring practice and academia together. That has been the essence of my career, whether I've been on the practice side of it or on the dark side of academia. You have been the inspiration, and I consider you really my mentor, and my wiser, smarter, more grace-filled person whose life and work I try to emulate. And thank you for everything that you've given to this institution, the Council on Linkages, but more broadly, Bill, what you have done is to impact the lives of countless people and communities because of your efforts to bring academia and practice together in a way that really has been second to none. So thank you for your friendship. If I had a bottle of Legendario right here in the office, I would raise a glass to you. So thank you, Bill.
Yeah. Oh my goodness. Thank you, Paul. I do have a bottle of Legendario in the next room. I think after Legendario, for those who don't know, is a Cuban rum. Paul and I are on the board of medical education cooperation with Cuba, and we've raised a glass or two of that rum in the past. I will do again in your honor. Thank you.
Thank you. My honor.
Any other comments and well wishes? And Bill, you will be receiving a little electronic card shortly after the meeting that many council members and others have signed with their thank yous. But let me see if there are others here.
May I say something?
Absolutely not.
Okay.
You may in a moment. You may in a moment. I before you say anything. Okay. You know me. I've got nothing to say. Ever.
But you take a great deal of time saying.
Right. But you know, building on Paul's comments and Gary's comments, you know, I earlier past few days, past few weeks, I've been just thinking about words that to me are Bill Keck. And I think of humble, I think of kind, I think of caring, wise, strategic, impactful. All of that. And I think about it, and I remember many moons ago, before I really got to know you, you already were council chair, but I really didn't know you, and you were on a panel, it probably was APHA, and I was asked to facilitate the panel. And you know, as a facilitator, you're provided the bio of the people who are on the panel. And I'm looking at that bio, I'm going, oh my goodness. This man has accomplished, has done, has taught, has been in, you know, brought people together, has run a health department, has run a preventive medicine program at the same time, all written. And I'm thinking, oh my goodness, I never realized it until that moment because of your humility and your way of going about things, of making somebody who was younger in their career feel important and feel like they belong. And to that, thank you, Bill, for your grace, your humility, and all you've taught over the years for so many of us. So sorry that I had to just chime in there, but you know, it's me.
Oh, yes. Well, I am humbled by all this. Thank you all so much. You should understand, however, that being council chair isn't really hard work. And it's because we're supported by such a tremendous staff. So Ron, right back at you. I mean, look at what the Public Health Foundation has done and become over the past 25 or 30 years when it looked like it was going to go out of existence when you were first hired. You know, look at your insights and connections and willingness to take risks and to move ahead and to make that organization into a real central part of public health in the United States. And then look at the staff you brought with you. I mean, working with you and Kathleen and more recently Mayella and Grace and others has been usually a joy, not always, I'll say, but usually a joy. And you make it so easy. So all I have to do is sort of sit here and make suggestions or pontificate a bit. And I'm not really concerned at all about the council because I happen to know Amy Lee very well. Amy and I have a long history, not quite 30 years yet, but getting there. It's close. Amy's been a mentee and a friend and a colleague for a long while, and is just an amazing person. So I think the council will be in very good hands. So I thank you and everybody on the council. I'm humbled by what you said. There's not much I can say in response to it except thank you all. And I'm not completely leaving. We'll still have the academic health department learning community, as well as staying APHA rep for a little while anyway. Although it won't be much longer before it's time to get somebody who's relatively new in this game and has a long career in front of them to work with you. It's been a pleasure. Thank you all.
Well, thank you, Bill. We should give a big round of applause for. Thank you, thank you. And Bill, guess what? The meeting is turned back over to you.
Yeah. Okay.
So you still have the rest of the meeting here, and there's some other business.
I'll tell you, chair's work is just never done. Well, that is the end of the meeting. Thank you all for participating. The next time you meet, Amy will be in the chair's position, and that next meeting is scheduled for September 16th, I think, right? September 16th, starting at 2 p.m. Eastern time. And as usual, if you have any questions, comments, or concerns that come to mind as the meeting comes to an end, please feel free to get in touch with any one of us to express what they are. You know how to get in touch with Ron and Kathleen and Grace and Mayella and me if you wish. So please feel free to do so. So is there any other business that we should discuss at this point?
And I think Kathleen had an item.
I do, and it's right here
Mm-hmm.
on the screen. So we just wanted to extend an invitation to you all to our Public Health Learning Forum. The 2024 Public Health Learning Forum will take place this October and is focused on workforce development in action. So you will see the council's footprints, I don't know what the word is for that, all over it. We'll have sessions related to the core competencies, related to academic health department partnerships. And we're really looking forward to the event. We'll be holding 8 sessions over the course of 4 days and have speakers from health departments and academia on the agenda. And registration is open now. The event is completely free, so there's no registration fees or anything like that. All you need is a Train account to be able to log in and click the button to register. And we're holding it through Zoom, so it'll be just like these meetings from that respect. The QR code on the screen should take you there, as well as I know Mayela just put the link in the chat also. So either one of those will take you to registration. If you have any questions about that meeting now or later on, feel free to get in touch with me. And we hope you're able to join us. And with that, I will say my great big thank you to Bill. I thought about this part of the meeting. So I've known this was coming for years, right? Like Bill has threatened every time we have an election to not run again and finally take retirement seriously. But we delayed and delayed and delayed. And now I've been thinking about this part of the meeting for weeks and I have no idea what to say. So I will just say thank you. We owe you all huge debt of gratitude. Much like Paul, you've been my inspiration my whole career. I've worked with you and Ron for my whole career at this point. 14 years now, it's hard to believe, but it has always been a pleasure and we very much appreciate it.
Thank you, Kathleen. I hesitate to ask if there is anyone else who has any comments at this point. Very good. I think we're at the end of the meeting. Gee, 7 or 8 minutes early. How about that? Well, congratulations to all of you. We'll look forward to the next meeting. At least I'll look forward to participating in the next meeting while Amy chairs it. And with that, we'll say good afternoon to all. See you next time.
Thank you, Bill.
Thank you.
Righto.
Yeah.
Bye-bye now, everyone.
Bye.